going to turn us on? They're on. Aha. Aha, ha, ha. Now it's working. I'm not just speaking to myself. Hello, everybody, and welcome. The sun has come out. Hooray. And this is a menopause panel which had the rather amusing title, is it hot in here? But it's actually not very hot. It's quite nice and breezy, so that's good. We're going to have the idea of this session is that we also involve, lots of you, and I know lots of you have got questions. I was talking to some of the ladies here earlier, and we're really, really lucky today to have a proper doctor with us on the panel, Dr Nighat Arif, who's you might know from the telly. Who's the doctor on This Morning and BBC Breakfast. And I'm very proud to say that Nagat she's also part of my organisation. My name is Eleanor Mills, and I run a new website for women in midlife, which is called Noon, Noon, as in the middle of the day, because we reckon as you hit 45, 50, you're only halfway through. And we're all about reinvention, transformation, and optimism about the years ahead. We see this as a real age of opportunity, and I think that that's an incredibly important message in a culture which is telling us we're done. We're not done. It's noon, almost at noon, so much more to come. I really believe that. So that's why I think menopause is a really important part of us talking about and thinking about the later stages of women's lives and making new maps of them and talking about what they mean in a culture where the voices of older women and their wisdom is too often marginalised. And also what's marginalised is our medical needs. We're 50% of the population, and we'll talk in a minute about the lack of medical training, the lack of information out there, and also some of the ways that this debate can get framed. I think it's good that we're all beginning to talk about menopause more, but it's still pretty bad in this country, and too often it's entirely framed by white women, which is why I'm really, really happy today to give this a kind of broader cultural slant. My friend Catherine Mayer, who's one of the founders of this amazing festival, there she is in the orange hat, talks about the stage as the world as it should be. And I think that this conversation is, very much reflecting that. So my other amazing panelist, absolutely, definitely not last but not least, is the creator of the amazing Masala podcast, which just won 2 prizes at the British Podcast Awards. And she's also the head of Soul Sutras. This is Sangeeta Pillai, and she is all about busting taboos in South Asian cultures around menopause and all those subjects around women's health that too often are not talked about. And it's pretty bad in the West. It's can be even worse in other places. So I really want to kind of give this debate a kind of global framing, and then we'll get into some more specific questions from people in the audience. But because we've got Nighat and Sangeeta here, I think this is a really amazing opportunity to talk about some of the taboos that maybe we don't even know about. And I know Nighat is our doctor on Noon, and I know she has very strong feelings about the absolute kind of poor relation that women's health is when it comes to things medical. So, Nagat, do you want to kick us off?
Yeah, hi, hello. I'm Dr Nighat. I've been a doctor for 14 years, and I do women's health and particularly a lot of education around menopause, but I do menopause education for South Asian women. The reason I got into menopause was because I had a very tragic event which happened within our own family. I get a lot of women from my community who speak Punjabi or Urdu, so English is not their first language, where I live in Buckinghamshire. I used to work in Slough and Southall, so if anybody of you guys know that area, know that there's a huge South Asian community who, for them, English is not their first language, but they'll come up to me and say, I've got brain fog, I've got aches and pains, I've got ringing in my ears, I've got itchy eyes, and I sometimes get a hot flush. My doctor thinks I might have fibromyalgia. Or my doctor thinks I've got depression and they've put me on antidepressants. Or my doctor doesn't know what's going on and they fobbed me off and left me outside. And I was a doctor who couldn't put all those hodgepodge of symptoms together. But what happened was that a dear family friend of ours was diagnosed with fibromyalgia, put on steroids. She had a fractured neck of femur. She was 54 years old. Because women who go through menopause and then put on steroids, unfortunately, that puts them at high risk of osteoporosis, which is thinning of the bone. She ended up in a wheelchair and passed away 5 years later. I was then a much more senior doctor, got far into my education and realised, hang on, hot flushes, night sweats, irritability, brain fog, vaginal dryness, depression, low mood to the point where she was feeling suicidal, the aches and pains that she was experiencing, the urinary tract infections that she was constantly getting, they're all symptoms of the menopause. Isn't that crazy? Like, what? There's about 42 different symptoms. And we have to think of the menopause as a hormone deficiency condition. It's not a condition that actually you end up just going through. It's not a beautiful phase in your life. I'm really sorry if that is how some people view it. But actually, it is because there are two hormones, the estrogen and progesterone in your body, that says, I don't need them because I've gone through my fertility years. I'm not going to get pregnant anymore. Thank you. Goodbye. And now I'm here at this stage of my life. But actually, for some women, that can really have a detrimental effect on their physical and mental health. And we as doctors haven't recognized it. I'm going to say this once, and I get shot down for it. I've said it on many, many platforms before. Medicine is misogynistic. I say that as a doctor, and I say that as a doctor of 14 years, and I get shot down for it by other doctors, but it's true. Until I see the evidence contrary to that, then tell me, and then come and educate me as a doctor. Women get 10 years before they get a diagnosis of endometriosis. Women are not offered pain relief by the Royal College of Gynecologists to have a coil insertion. 2021, we offer them paracetamol and ibuprofen. What? We sort of have to tell women to double guess themselves if they want to have an epidural for pain, pain relief when they're giving birth. What? You should be telling women that before. We don't even teach girls or boys at school from the age of 16 what menopause is, this important stage in your life which has health complications. If I have 4 women in my room as a doctor, one of them will go through some of those 42 symptoms and she'll be fine. 2 of those women will go through some of those symptoms to the point where she might want to leave her career. She might feel that she's really low. The hot flushes are keeping her awake. 1 in 4 women who are going through menopause feel suicidal. What is medicine doing about it? And that is, I think, something that I feel really passionately about because it's across all generations. And it doesn't matter about how educated you are, not educated, but the statistics are there. 74% of the NHS is actually made up of women. Okay, we're a huge sector. Women love to be caregivers, doctors, consultants. But did you know about 15% of that sector leave their profession? Women leave their job around the age of 42. Highest rate of divorce rate happens around the age of 52. It's back bang when the woman is going through menopause. So it's not just an effect on your health. It's actually your livelihoods. You're not going to earn more. You're not going to be able to break through that glass ceiling at work. And then you'll be left right back to where you were in your 30s, unsure where you're going because the gentleman next to you who has probably less experience has gone higher up. Because why? Your menopausal symptoms of hot flushes and night sweats are keeping you awake. And I just think that's unfair. And so we as doctors need to do more, and we are doing more, I promise you. Well, for one, you guys are here listening to me. I mean, that just shows how phenomenal it is, because in all my years as a doctor, I've never gone to do a talk about menopause before. So I think that's telling.
Is that true?
Yeah, I've never, apart from other doctors in a room, I've never had general population, like the average individual, come and see me and ask me about this. And then also, I think social media has blown this apart a lot because we can't deny that those platforms are giving a voice to women who are saying, please do better. So I'm happy to take some questions, and I promise you we'll do better.
I want to move on to Sangeeta, but before we do, will you just tell us quickly about your medical training? How much training did you get on the menopause when you were training to be a GP?
So to be a doctor, we get 6 years to become a doctor, straight from A-levels. We have half an hour in those 6 years to be taught about women's health.
Yeah,
honestly.
That's the whole of women's health. That's not half an hour on menopause. I just think that's so shocking.
And then you're expected in 4th and 5th year of your medical training to do women's health and go through gynecological training. But you're taught on mannequins, so plastic models of women, and male GPs, male doctors, unfortunately, some of them don't have any experience apart from examining a mannequin. And that's because for a male doctor to examine a woman, you have to have a chaperone, and it's expected that those male doctors will go and learn in A&E when the trauma patients come in. But actually, to do a chaperone, the demand in A&E means that a lot of them shy away from it. And when I was doing A&E, my colleagues said, well, Nagat, you're the woman. Can you go and examine this patient? So I then picked it up. Then doing gynecology, which is a rotation of 6 months, is not offered to all trainees. I had to fight to get my rotation because I wanted to do women's health. So, but also within medicine, there is this thing that, you're going to see vaginal discharge and vaginas all day. Oh, I apologize if that offends anyone, but I will be talking about vaginas and penises a lot. I know I wear a hijab, but we have to use the right terminology. Honestly, I still get like grown women who won't know what their vulva is. So we'll talk about a vulva as well, because vaginal atrophy is one of my favourite topics.
I knew that I had to hire Nagat to be the doctor on Noon when I started hearing her talking about vaginal discharges on TikTok, where she has a huge audience of women all over the world.
But then when you become a GP, menopause again, you're given maybe sort of 2 or 3 weeks to learn about it. But it doesn't really go into hormone replacement therapy because around the 2000s, there was a study that came out, the WHI study. And I don't know if a lot of you know about this, but this was a flawed study which said that estrogen equates to breast cancer. I was a junior doctor then, and then I was actively told by my team of doctors to start taking women off hormone replacement therapy. And I think that was detrimental to the extent where we are, to the point where we are, where there's a fear amongst doctors to even prescribe hormone replacement therapy. So the Royal College of Obstetrics and Gynecology and the British Menopause Society, we all know that menopause training is lacking. You're not taught it as part of the Royal College of GP's curriculum, but 50% of my patients are women. So we are where we are.
Thank you, Nagat. That was definitely sobering. The half an hour training on all women's health never fails to shock me, even though I've heard it many times. So Sangeeta, let's use that as a jumping off point to talk about some of the kind of broader taboos and the work that you do, again with Southeast Asian women, and some of the taboos that you're trying to chip away at when it comes to these kind of subjects.
So I run a network for South Asian women called Soul Sutras. All the work I do is taboos in the culture. Now, if you know any South Asian people, there are a lot of things we don't talk about. We don't talk about sex, we don't talk about periods, we don't talk about menopause, none of that. It just doesn't exist. And with Masala Podcast, which is what I run, I do interviews with other South Asian women. Each episode is a taboo. So we kind of delve in deep. To give you an idea of how it is in my culture, so I speak 3 Indian languages. I don't know the words for breasts or vulvas or menopause in any of those languages. That's how little we speak about it. So as far as our culture goes, menopause doesn't exist. So I'm never going to have the menopause because I'm South Asian. So that's how unacknowledged, unspoken it is among mothers and daughters and sisters. You know, this is happening to all of us, but we just don't speak about it. So it's not just the menopause, it starts much earlier. We don't talk about, one of the first things we teach our kids is a word called chi-chi. Chi-chi is dirty, it's shameful. So if a kid's running around naked, you'll say chi-chi. So you associate being dirty with being naked. So then you don't talk about nakedness, you don't talk about puberty, you don't talk about periods, definitely don't talk about sex. I grew up in India, so all the Bollywood films, you'd have, this is how I learned about sex. So hero, heroine come together, there's a close-up, then there's a shot of 2 flowers, like random flowers. Cut to baby's born. So I'm like, oh, must be something to do with flowers and people, you know? So these conversations are just not happening. And I think what Dr. Nighat has pointed out, within every culture, but particularly South Asian culture, it is so important to acknowledge we have bodies, we have periods, we have the menopause. Because at the moment, the way I think South Asian culture views menopause is like, we think of a menopausal woman as this white, middle class, silver haired, very, glowing with health kind of woman doing yoga and Pilates. It's nothing to do with women like me. So unless we change the narrative, unless we start having these conversations in our languages, so people can then say, hey, this is happening to me, I'm having a hot flush, or what do? I go to my GP. So these are very, very crucial conversations. So 50% of the population of this planet will at some point go through the menopause. So why are we not talking about it? Then I think the other sort of issue within the culture is the other side effect of menopause, which I know most women going through it will have some sort of mental health. I've got anxiety, depression. We don't address those. We pretend mental health as an issue doesn't exist. So already you've got that barrier. Then you've got menopause on top of it. So that's like a double whammy. So we're not even going there. Also, the kind of way we're brought up, kind of growing up in India, and also South Asian women here, like the ultimate goal of being a woman is to get married and have children. Like that's your primary purpose. So if you haven't reproduced, what is your point? So if then you're saying that now you can no longer reproduce because that is what the menopause is, that's, again, my God, we're not going to talk about it. So yes, we should have more of these conversations in South Asian culture, in all cultures, I think.
Do you see signs of this changing, Nighat? A lot of the kind of outreach work you do on TikTok and that kind of thing. Do you want to tell us a bit how that works and why you started doing it?
I think the fact that you guys are here, men and women, different backgrounds, different economical backgrounds as well, because I think that's really poignant as well. It's always been seen as a rich woman's condition, and I definitely would always see the highly educated, more upper class women that would come and see me in my practice, and everything else would just be ignored. So and definitely seeing women of different colours. So for example, knowing that we can just have this conversation across, but there's no boundaries, and change is happening. I'm seeing it. And that's why I got into TikTok. Yes, I make TikToks. I'm very proud of it. I don't dance, so that's one thing. And I do a bit of lip sync. But on a serious note, it's very hard to lip sync about vaginal atrophy. But on a serious note, the people that are watching my TikToks are from South Asian backgrounds, Africa, Caribbean backgrounds, and younger people, so 20, 30-year-olds, because their mums are going through it. So they're saying to me, my mum's got these, I didn't realise that this was the menopause, and then they're showing their parents or their mum and dad about it. There's this myth that you go through it and it finishes. Unfortunately, the menopause, because it's a hormone deficiency condition, you are in it till the day you die. All right, so I'm really sorry. I know. Whoop, whoop. Yes. No, but...
so is that true medically? So your symptoms won't go away? You'll go on having kind of menopausal symptoms forever?
And 80-year-olds. Okay. Estrogen and progesterone are the two hormones that you'll end up losing. If you have a womb, then obviously those are the two hormones. Estrogen, we've realised, is a lubricant. It lubricates everything. So from your tiny little brain cells all the way down to your toe. And we need it to keep things nice and healthy and replenished. As that loses, then what happens is there's two things that happen. Around the midlife, you start putting on a bit more weight. So because your fat cells is what will produce estrogen for you, because there's lots of different places that we produce estrogen. In our brain, in our womb, and then the fat cell also produces estrogen. So you'll find that little bit of middle weight that starts to happen. That's normal, okay? And women go on these extreme diets to try and lose it. It's normal. It's because your body is trying to do the reverse of what happened around puberty when you started putting on that puppy fat to start your periods. Well, the opposite's going to happen now. And so that's one thing. But then secondly, you start losing that weight as you go through some of the worst bits of menopause. But then those symptoms of a lack of estrogen do come back. So hot flushes, memory fog, irritability, they will wax and wane, because wherever your body is finding a dip in estrogen, those symptoms will reoccur. So this belief that actually what happens is that you go through it and you're absolutely fine, it doesn't. It all depends on how much of those fat cells offset your womb, which isn't producing, or your ovaries, which isn't producing the estrogen. I hope that makes sense, because that's the easiest way I can explain it medically. And we've only really recently come to realize that, because we've realized that estrogen is so important, we need it. And because it lubricates everything, it helps us from not have dementia. So more women are likely to become to suffer from dementia. Why? Because of lack of estrogen. More women are likely to have osteoporosis. And there used to be this myth that only women who are really, really skinny or underweight get osteoporosis. I, as a doctor, have seen osteoporosis in women who are healthy weight. Why? Because of lack of estrogen. More heart disease in women. Why? Because of a lack of estrogen. So the importance of estrogen has always been undermined because of the WHI study. But it's really important that we understand that it is a hormone deficiency condition, and we need to manage this properly.
So as a doctor, do you advise your patients to take HRT? And in which case, kind of what kind? And is the stuff that's usually doled out the right thing? I mean, we've heard a lot recently about kind of more tailored kind of phytoestrogen and that kind of thing. Can you give us a bit of a sense of that?
So estrogen the great thing is it's in a lot of stuff. So soya, loads of food products that we have natural estrogen around. Your body will naturally produce some estrogen as well. So we do have some of that. Hormone replacement therapy is a completely individual choice. I never force anyone to go on hormone replacement therapy. And if you want to go on it, actually the NICE guidance is a really good place to start to read about it. There's no age limit. So there's this other myth that's out there. I can't go on hormone replacement therapy because I'm 42 and I'm still having periods. You can still go on hormone replacement therapy if you're having the menopausal symptoms. And then hormone replacement therapy comes in different ways. So if it's estrogen, it can come as tablets, patches, or as a gel. And then there's something known as body-identical hormone replacement therapy. I'm just really worried that I'm telling you guys so much information that you're going to glaze over soon because it's very medical. And then you can get progesterone as capsules or through the Mirena coil as well. So there's a whole range of different types of hormone replacement therapies out there. There's just not one. And not one size fits all. Every woman is incredibly unique. Your personal history, your medical history, your family history of breast cancer, they will all play a part in that decision about hormone replacement therapy.
So if there are women here who are thinking that maybe that's something that they might like to try or talk to their doctor about, how do you go about making sure that the doctor's going to give you what's right for you? Because we've had so many women on Noon writing for us saying they've been given a kind of one size fits all pill, and it's actually made their symptoms worse. And I know, speaking to people like Dr. Louise Newson or to you, that you can get these things much more finely tuned. But are they available on the NHS?
Yes. So body identical hormone replacement therapy, estrogel and utrogestan is available. The Mirena coil is available. And those are the only things that are, unfortunately, testosterone, which is another hormone, the third bit of the hormone that women need as well. Because remember, we produce testosterone in our ovaries, and as we go through the menopause, we get a 50% reduction. So why do we need that hormone? Because men have it, surely. So why are you talking about it? Well, the reason we need it is because it helps our libido, it helps our memory, it helps our fatigue and energy levels. Unfortunately, as I started off this conversation earlier saying medicine is misogynistic, the healthcare sector does not deem that testosterone is something that women need for their libido because it's a choice. And that is atrocious. But we're working on that to try and change it.
So Nagat was in the Davina McCall documentary that some of you will have seen about menopause, and we were chatting earlier about just how that's kind of opened up a conversation. Tell us a bit about your experience of that.
So it's opened up the conversation two ways. There was a bit of an issue with doctors saying that now more patients are asking for hormone replacement therapy. Go figure. I mean, so I had colleagues text me and say, "We saw you in the documentary, Dr. Nighat. It's nice to know that Davina is telling me how I need to prescribe hormone replacement therapy," which just shows the lack of insight that we have as doctors sometimes. I know I'm doctor bashing, which I appreciate, but I think that we do lots of things absolutely right as doctors, but when it comes to hormone replacement therapy, we do still feel that as a profession we know better, and that needs to change as a culture, not just amongst GPs but against the whole medical profession. And then secondly, the way it started the conversation was that women were able to put the dots together themselves and realize what they're entitled to, because there is an area of secrecy about hormone replacement therapy. Nobody wants to think about getting old. I mean, that happens to, Miranda on the other side. Sorry if anyone wants to call Miranda. But that happens to somebody else, not me. I don't get old. I'm perfectly fine. But unfortunately, your years in puberty are finite. Your years in fertility are finite. But you'll spend 4 decades in the menopause.
Yeah. And yet, the doctors get half an hour in 6 years. So I think what we need is a kind of much bigger campaign around all of these subjects. Yeah. And I know that some of that campaigning has come out of the Davina program, which I think is good. But I also think it's part of a bigger conversation around midlife and women's lives at this point not really being talked about, not being mapped, us not telling the new stories. I mean, you talk about in your culture the kind of taboo around being a woman who doesn't have children, but certainly what I find out from my platform is around a third of Gen X women who are university educated don't have children. So therefore our whole cultural narrative around older women are necessarily kind of grandmothers, or that's the only kind of stereotype that we see, is completely wrong. I spent 25 years as an editor on the Sunday Times, running all sorts of articles. I edited the magazine and all that kind of thing. And it was really hard to get pictures of older women into the magazine. Even if you'd photograph some incredibly famous actress, you'd go to the editor with your cover of the magazine, and usually the editor would go something like, "Oh, haven't you got something a bit fresher?" Or, "Can't we use a picture of her when she was, when she was younger?" I remember going in with an incredible shoot of Charlotte Rampling that we'd had done, kind of now her in black and white, and one of the most iconic women in the world. I couldn't get the photograph on the cover. So there's a really kind of broad kind of it's a kind of misogyny, but it's really where ageism hits misogyny. It's where ageism hits sexism. And when this menopause conversation is actually, I think, a much, much larger conversation about the value that we put on the later stages of women's lives and how we define them for themselves. And I think that matters not just, I've just turned 50, so I think it matters not just for women at this stage, but for all the women coming up behind us. I want them to look at this stage in their lives and see it as an age of opportunity, a time when you can do great stuff, when some of your family responsibilities kind of shift and lift, and you know a bit more about who you are. And I want my daughters to look forward to their 50s as this massive time of possibility and achievement. And yet I don't see that reflected in the broader culture around me at all, which is why, as a journalist, I really decided I wanted to tell these stories. I wanted some stories of kind of inspiration about what was possible for women at this point. And
if I might add something,
yes.
it's really annoying that as a culture, everything young is desirable,
yes.
Everything older is to be hidden.
Yes.
And we all do it. Like, I'm 48. If someone says to me, "Oh, you look young for your age," I go, "Oh, thank you." Because I'm conditioned to think of that as a compliment. And everything from fashion to magazines to telly makes us think that growing older is a bad thing. It's something to be hidden. And traditionally, if you think about it, cultures don't necessarily, like South Asian culture traditionally, there was value in growing older. They were the wise ones. They were the ones who kind of the matriarch of the family. African cultures as well, if you look back. So somehow that's become this obsession with youth and value for youth and only for youth and nothing else. I think it's not a very good narrative. It's not a healthy narrative, I don't think.
No, the voices of older women are marginalised and repressed in all cultures. I mean, this is something that goes across, all races and cultures predominantly. And I think for me, it feels like one of the last kind of bastions of feminism as well, that it's one of the really kind of key parts that we don't value ourselves in the way that a patriarchal society does, which says at this point we become valueless. But we say that's wrong. We have different kinds of creativity, of fecundity, which goes on into our later lives, which is not all about children or family either. There are lots of different ways to be creative and productive. And that's a conversation that I think is really important for lots of women, as we all live different kinds of lives. It's wrong that the only trope that's allowed as you get older is this one of being a grandmother. So it's something I feel very passionately about, and I think that we need a kind of broader conversation about. I'm also aware that Nagat started off by talking about how this isn't a kind of beautiful phase. I mean, I'm slightly more ambivalent about that one. I've been reading quite a lot of people like Jewel Wingfield, and I do think that there's something in the kind of rituals around this later part of our lives and what we discover about ourselves and moving into a more of a not taking any shit from other people and kind of trusting yourself more and not caring less about what the world thinks. I think that's really important. We need to be modelling that for a lot of younger women coming up behind us. So
Yes.
I think that's really
Sorry,
important.
didn't mean to interrupt you.
No, go.
Isn't it also like the menopause is a time for revival? I feel like
Yes.
everything kind of shakes up. Like, I think I'm getting into perimenopause. In the last 3 years, I've kind of quit my advertising career of 20 years, set up Soul Sutras, started a podcast. So I've turned my life upside down. And I know a lot of women do that. It's suddenly you're like, my God, where's my life? I'm at a crucial point. I need to figure out. So it can be positioned as a time for change, for positive change.
Yeah.
And again, we don't hear those stories.
No, well, that's exactly what my platform Noon is doing. It's all about those positive stories. I was made redundant from my job. I felt completely lost. I'd done it for years. It was my status. It was my life. It suddenly wasn't there. And I looked around online for stories of other people who'd been through a kind of, dark dip in midlife and come out of it. And I couldn't find anything. So I decided I would start publishing some of those stories myself and try and help people through that transition, that transformation, and make them feel optimistic about it. And I completely agree that starting again at 50 is great. I've become a founder. I've done all sorts of things I've never done before. And it makes you feel... I got into trouble the other day because I said it made me feel young again. It doesn't make me feel young again. It makes me feel reinvigorated. It's like a renaissance. It's a new stage. It's not about being young. It's feeling like you're living life in the fullest way that you can. And I think that's what we need to talk about. It's not about feeling young. Often that feeling is associated with being young because you're in that state of development. You haven't kind of crystallized exactly what you're going to be. But I think that we can get back to that state of renewal at any point and that we should feel excited about that. The Chinese call the menopause the second spring. And I think that this part of our lives can be that, a kind of reflowering, a reimagination. So I think on that note, let's take some questions from all of you in the audience. Yes, lady here in the middle in the hat. Is there a microphone?
Firstly, I really like the idea of celebrating a menopause renaissance. I think that's brilliant. Secondly, I would really like to acknowledge that menopause isn't something that just women experience. It also impacts obviously trans men and non-binary people.
Yes, of course. Sorry.
As additional complexities to the discussion. Thirdly, as someone whose medical history means I can't take HRT, what other things can I do to alleviate the symptoms? Because I would say I'm one of the 1 in 4 people that hit suicidal. Yeah, I know. Hit suicidal. You're 1 in 4 women who hit that end of the thing, but I can't take HRT. So what other things can I do?
Great question. Thank
That's
you.
a really good question. And I also love the fact that it is a second coming. I think I meant it in a way that in medical terms, as doctors, we've always seen it, this is a natural phase, a normal phase. So that's why anything in medicine that's seen as, well, this is normal, we don't pay attention to it. And so I think that's more than the fact that it is, I totally agree. I've seen more women do fundamentally phenomenal things when they've gone through their 40s and 50s and then their 60s. They've just phenomenally done amazingly. But that's some of the reason why I've realised in medicine why menopause has been ignored for so long, because it's always been termed as a normal process when we know that it's not. Because as you said, you're that 1 in 4 that got to the point where you're feeling suicidal. That's not normal. We've all got to acknowledge that. There are alternatives to hormone replacement therapy. So, for example, again, not one size fits all. I always say to women that as you're approaching your 40s, preparation is key. So start taking a multivitamin. I'm not sponsored by them, but taking something like Vitobiotics called Menopause or Menopause Plus. It's got soya, it's got sage in it, it's got magnesium. 84% of women who are going through the menopausal phase of their life lose magnesium. Magnesium, we need that for sleep, the chemical reactions within our body. Calcium, we need vitamin D. So it's a really good idea for about 3 to 6 months to take Menopause. Number 2, yoga and acupuncture fantastic evidence-based trials which have been randomly controlled to show that really great at reducing hot flushes and really helping with sleep as well. And I can't deny that exercise just does wonders, even if you're not through that phase of your life, but exercise and carrying that on. For sleep, primrose, if you want to take primrose. So these are all natural things that you can try. Lavender, baths, etc. Then we go into medicine. So SSRIs, so serotonin selective reuptake inhibitors. Many of you might know them as antidepressants or something called citalopram or another version called venlafaxine. Now, before you go, oh my gosh, the doctor wants to put me on antidepressants. No, it's not antidepressants. Small doses of antidepressants are actually fantastic at alleviating menopausal symptoms. So I put women who have hot flushes and night sweats and anxiety on venlafaxine, 75 milligrams, moderate release, and say to them, take this because it will really help your symptoms. Then we have something called clonidine, which is another medicine, which is a type of a blood pressure tablet, but brilliant at relieving hot flushes. And then we have gabapentin as well. Again, really helps with the aches and pains, night sweats and hot flushes. So there are alternatives for women who can't have them. There are risks and side effects to all of these medication. That's why your individual history is really, really important. The other thing I just wanted to say on hormone replacement therapy, it is not a silver bullet. So to go on hormone replacement therapy, I always say to women, regardless of which type you go on, give yourself 3 to 6 months to get used to the type of hormones, because your body is still going to produce the hormones at its own level. What I'm trying to do with the hormones that I'm giving you as a gel or as a patch is to try and dovetail that between what your normal body is producing. And any type of hormone replacement therapy that we put you on will make you have a period. So there's also this, and not all doctors know that. Yeah. So hormone replacement therapy is literally, I'm replacing what isn't in your body. So the first thing that happens is if I put you on estrogen, progesterone, which is what you'll need because you have a womb, your body suddenly goes, oh my God, this is amazing. I've got estrogen. And the lining of the womb comes back up, which means that you will have a period. So if you haven't had a period for over a year and you started going on hormone replacement therapy, your periods will come back. Do not panic. That's nothing to be scared of because you're on hormone replacement therapy. And the guidelines say we don't need to investigate that for up to 6 months. And then after 6 months, it goes away and it settles because your body realizes what's happening. And so there are not amazing side effects. You know, some women don't like the thought of that or they get really worried, but it does settle. And it's only if you've had bleeding longer than 6 months on hormone replacement therapy that we then would send you for a scan and investigate you. So it's an individual choice, non-hormone replacement therapy, hormone replacement, and then going through the side effects.
Great, let's have another question. Catherine with the orange hat. It's your festival. It's all hat.
Yeah, this is still not on. Is it? No. It really isn't. You just give me something that's very suggestive. You can hear me anyway, can you? This is from the 60-somethings corner over here. So both of us, in theory, through the menopause, although we're not quite sure of the definition of that, because, we're beginning... this is a rap record.
You can do a TikTok too.
No, but so like the definition of menopause is what, a year without a period, you're in it. But it's really hard to say when it finishes, and particularly for both of us.
We were just like, this ship sailed, we don't need to go to this
we
workshop.
weren't even sure about coming to this panel, but we were interested in what you were saying. But we're now sitting here wondering, is there still, because you talked about like being through the menopausal phase, but you also talked about things like loss of bone density. So is there actually value in, neither of us did HRT, neither of us, she took some supplements because she's good that way, I didn't do anything.
Yeah.
But is it too late? Or
It's never too late. Yay. It's never too late.
So for those of you who couldn't hear, Catherine's saying, so if you're in your 60s and you reckon you're through it, but you've never taken HRT, is it a good idea to do it?
Okay, so firstly, can I just start with definitions, if that's okay? Perimenopause, I don't know if any of you guys have heard of that. It's sometimes known as menopause that's early menopause. Perimenopause is when you're still having periods and you have menopausal symptoms. The average age of that is around 40, starts around that age, and you can still go on HRT. Menopause is defined as 1 year without a period. So when you've had 1 year without a period, then you know that you've gone through it. Post-menopause is 1 year and 1 day. It's literally just as simple as that. So then you know that you're now in the post-menopausal phase. Then there's also something known as premature ovarian insufficiency. The youngest in the UK is a 15-year-old girl. So that's when your ovaries stop functioning and you don't produce estrogen. It can happen at any age, actually. And that is when you also go through the menopause as well. And then there's something known as surgical menopause. So surgical menopause is what we as doctors have put you through, because what we've done is we've removed your ovaries. We might not have removed your womb, or we have removed your womb. But what happens is when you've had your womb and your ovaries, or whatever, out of those, taken out. So that means that your body then goes into this surgical menopause. And you need different types of hormone replacement therapy. The NICE guidance is absolutely clear from 2015. There is no end date for HRT, and there is no start date for HRT. It's all based on when the woman feels it's necessary and if her symptoms warrant it. So if I've got a patient who might have a history of osteoporosis, or she's at risk factor of having osteoporosis, so risk factors of osteoporosis: family history, low BMI, smoker, high alcohol intake, lack of vitamin D and calcium in your, lack of vitamin D and calcium in your, sorry, Catherine, I've outed you. So if those risk factors fit that patient, then what we would do is we can either do a DEXA scan, so send you off to have a look at what your quality of bone is like, and then decide on that whether you need to go on HRT or not. So I hope that answers it.
And Kate Muir, was the woman behind the Davina McCall documentary, she keeps saying to me that HRT is actually really good at protecting against Alzheimer's, which is one of the biggest killers of women. Is that true?
One of the most telling thing for me was I used to look after a dementia care home of 90-bed patients. And this was back in when I was a junior GP. I'd started a Fremantle care home, fantastic facility. But I walked in and there were 5 patients sitting in the waiting room. 1 was man and 4 of them were women. There were more women being admitted into the dementia care home facility. And I then, and this is what, early 2000s, said to my senior partner, why are more women being admitted? Why are they getting dementia symptoms? And it was just literally like shrug of the shoulders, dunno. And we've now realised from lots of brain scans, and Dr. Gosh, her name has gone out my head, but I can see her face. She's done. No, not Dr. Neeson. There's an American scientist who's dedicated a life to looking at dementia because her own mum suffered from dementia. And she's realised that the connection is a lack of estrogen, because estrogen is a lubricant and we need it.
Yeah.
Can I talk about vaginal atrophy? Because I'm dying to talk about it.
You just can't stop, and then we'll take another question.
The reason being is because vaginal atrophy
love saying it, don't you?
Is because women suffer from this, and I would say 85% of women suffer from it. It's the most common diagnosis, but we miss it as doctors. And I'm picking up, but women don't know about it either. Atrophy is just a really clever word to say shrinkage. So we've all got vaginas and vulvas. Sorry, men, but but men, you'll know a vagina and a vulva when you see one. But our vagina and our vulva has estrogen receptors. It's covered in it, and we need estrogen to produce that natural vaginal flora, which allows us to get no bugs from the back passage into the front passage to stop urinary tract infections. It also allows us to feel comfortable and healthy. And also what it does is it allows us to have sex comfortably as well, and have smear tests, etc., which we need to have smear tests because it saves us from cervical cancer. When women are breastfeeding, it's as young as that. So breastfeeding mums are going to be early 20s, 30s. When you're breastfeeding, you reduce in estrogen, so you end up getting shrinkage of the receptors. Women as young as 40, I've realised through my clinical practice, end up having the same process, because that lack of estrogen means that you're losing those cells. So you'll get symptoms like recurrent urinary tract infections, itching, maybe dryness, but actually it's watery discharge. So there's this myth that vaginal atrophy only causes dryness. It's not dryness. It's this watery discharge. It might become painful having sex, which never used to be the case before. That smear that you had is a bit painful. And what happens is your body quickly tries to readapt and produce this estrogen, and it gives you a little shot. But then again, you get another urinary tract infection. A woman in her 40s does not get thrush. For thrush to survive, we have an organism called Candida albicans. Candida albicans need that lovely moisture atmosphere in that area to thrive. When we lose estrogen, Candida albicans cannot survive. So a woman in her 40s or 41, 42, 43 who says, I've got thrush-like symptoms to the doctor, that doctor should be thinking, that is atrophy. And the way to treat that is to give you vaginal estrogen. Vaginal estrogen is a different type of hormone replacement therapy. It's topical. It does not cause cancer. It does not cause clots. And if I had my way, when all my friends turn 40, I'd give them vaginal estrogen and a vaginal moisturizer. So that is literally what we should be giving all our friends. And saying to them, in 10 years' time, your sex life will thank me for this. Because it's something that I see lots of women, and particularly from my community, South Asian community, black women, who I see in my surgeries, is that they'll sit there going, I've had recurrent urinary tract infections, Dr. Arif, and no one can get to the bottom of it. And I examine them, and they've got atrophy that was preventable 10 years ago. This is a preventable condition, and we're missing it as doctors, and women don't know about it. So vaginal atrophy should be available over the counter like Viagra is. But again, the MRHA doesn't deem it's necessary. So
Vaginal estrogen.
Vaginal estrogen. And so you have to go to the doctor to get a prescription, and it comes as a pessary or as a cream. And once you're on it for life. So if anyone tries to get you off it, say no. The nice guidance says, I have to stay on this for life.
Do you use that on top of the estrogen patches?
Yeah, so 25% of women will need estrogen pessaries as well as having systemic. So there's hormone replacement therapy, which is systemic, so it goes throughout your whole body, and that's as a patch or a tablet or a gel. And then there's localized, so it will only work in that area. So for some women, like yourself, who can't have HRT, should definitely be on vaginal estrogen to protect you against vaginal atrophy. He's misinformed, I'll tell you that. Because that, unfortunately, they don't get taught menopause. And so they don't get taught about the estrogen that's vaginally topically used. Even gynecologists do not get taught menopause. Sorry. I know.
Ladies in the front here.
Hi, this is so informative. I actually suffered estrogen-positive breast cancer, and through the support services, they all categorically said you can't have HRT, and they gave me menopause training, which is really quite different from what you're talking about now. And I just wondered what your position on that was in terms of estrogen-positive breast cancer and HRT.
So I've actually put patients who've had estrogen-positive breast cancer on hormone replacement therapy. There's a book called Estrogen Matters by Avram Bloom that is well worth reading, because we've realized, okay, estrogen-positive breast cancer happens because we have estrogen everywhere. We have the most amount of estrogen in our boobs. Our boobs go up and down like anything. Every 2 weeks before you have a cycle, your boobs will change, or your breasts. The cells in those change, and then you'll have a period, and then those cells change again. And that cell change happens throughout your life, always. So the reason you have that estrogen-positive breast cancer is because the estrogen that's working there is allowing those cells change because you're having a cycle. So that's where, wherever you get cell change, mistakes happen. Wherever mistakes happen, that's cancer. But now we've realized that actually, that the estrogen that we give, which is body identical, same as your own body, which is either a patch or a gel, something called estrogel, can sometimes, in some cases, safely be given. But that's an individual consultation. It's an individual choice. Some women still feel absolutely petrified and don't want to go on it. That's absolutely fine. But it's a conversation that's well worth having. So after 5 years of being breast cancer free, and if a woman is having horrible symptoms of the menopause, I have put her on estrogel. And I've counseled her and said, there is a risk. But we must understand breast cancer risk. Could I have... Oh, sorry.
Yeah, I want to take a couple more questions. What are you going to say?
I was just going to say, breast cancer is so common. 1 in 8 women, so there's 1 in more than of that, 1 in 8 of you would get breast cancer. I'm not on hormone replacement therapy, but my risk of getting breast cancer is 1 in 8. Why? Because our boobs are up and down with every cycle. That cell change happens constantly. Hence why your risk of getting it is there. So do you then balance that risk with going, well, I don't want hormone replacement therapy, but I have these horrible symptoms because I've got this fear of breast cancer? It's a balancing act.
Yes, lady here in the blue jacket.
Yes, it does. In fact, my second largest audience is in India. And a lot of women write to me in the UK and in India to ask about, say, the menopause or periods, whichever issues we discuss, because they're not able to do that within their families, communities. So yeah, out of the 50,000 downloads, I think about maybe 20,000 is in India and the rest is in the UK. So it's a universal thing. Like we were saying earlier, half the world is going to go through menopause and periods. So we should be talking about it. Thank you for asking, because I think it's a bigger conversation. You know, we're having these conversations in the UK. Places like India are a little bit sort of not quite there yet, but it's starting. I hear a lot of Indian influencers on Instagram and things talking about sex positivity. And I was on a panel talking about vibrators the other week to an Indian audience. So, you know, we're doing these things. So it is a broader conversation. Thank you for bringing it up.
And do you find that when you have these conversations, both of you, coming from those cultures, that you receive a lot of kind of, you know, online abuse or criticism? I mean, I know, just talking about pornography or daring to say that older women, you know, deserve to be kind of seen and spoken to, I get abuse online. I wonder what it's like for you two. Is that a difficult
don't. Funny enough, I have had 99% positive feedback from women, primarily women. So almost every day I get emails, Instagram messages, Twitter messages saying, I was in my car, happened to listen to you on Spotify, and you were talking about the first time you had your period, and, you know, this happened to me too. So in my case, it's really, really, really positive. I get the odd man trying to chat me up, but, you know, that's...
How about you?
So incredibly positive. Just always, I feel that I wish I could do more, because I get more questions about medication and I can't have this, and I just cannot respond to that because it's not safe, but time and capacity is my work as a GP. And I also get, I think it's because I'm a overtly Muslim looking woman. And so, yes, I am Muslim, I'm a practicing Muslim. So I get most comments from my Muslim community, because it is such a reserved community, saying to me, surely you can do this in a closed room. That's something. And they'd be horrified that I'm talking about this in a tent. So
no, I was just going to say, this is Nighat's first ever visit to a festival. So this is a really massive day.
I know.
Their first talk in a tent. I want to take the question over here. Yeah. Oh, sorry. Oh, God, sorry. I can't see around the speakers. Yes, hello. I can see you through this
hi.
one. Go for it.
Is this? Can you hear me?
Yeah,
okay.
perfect.
Yeah. I used to live in Japan, and they always maintain that because they drink a lot of soy milk and they eat a lot of tofu and it's full of phytoestrogens, that they don't really suffer from the menopause in the same way. So when I was going through that, that's what I did, along with yoga and meditation and all sorts of stuff like that. And I don't tell many women this because they get really mad at me, but my menopause lasted about 6 months. My mother was on HRT for 10 years and really suffered with it, and I never, ever did. And I just wonder, what's your position on phytoestrogens?
Love phytoestrogens. A huge fan. There's lots of evidence based that they work really well. And I've got colleagues, and I've started talking to some doctors in Japan and China, and they do a lot of yoga and meditation, and there is a lot of evidence to suggest that works as well. Like I said, HRT is not a silver bullet. You've got to do lots of different other things. And so the one thing that actually what I find with women who sailed through the menopause, because that, if I can phrase it that way, in medicine, it's what we say, sailed through medicine. sail through menopause, they do end up getting the vaginal changes. So please watch out for that, because it's still worth going on topical vaginal moisturizers. So we moisturize our face to keep it nice and plump. We should be moisturizing that bit of skin. So there's some great moisturizers. There are 3 brands I recommend that you can buy from Boots or anywhere. Yes, Replens or Silk. Make sure it says moisturizer and not a lubricant. A lubricant is oil-based and allows better penetration for when you're having sex. Moisturizer is what's going to be taken up by the cells around the vagina and add moisture, that vaginal flora that you need, back into it. So it's something that it would be worth taking. It has got no chemicals, no HRT, nothing in it. So it's worth doing that. But yeah, it's great that it worked for you.
Person here just behind there.
Sorry.
Yes, sorry, you've been very patient. I've been looking at you, but...
Oh, sorry, would you... I just give them... We just have it here. There's a lady here first. That's all.
Oh, sorry,
sorry.
I've been looking at this person for a while. Go on.
I'd like to ask, are postmenopausal women without children more at risk from endometrial cancer? Because it's something that's not talked about very much at all.
The data on that is still lacking. And I know the studies that you're referring to, because we've been watching them actively. Having children, not having children is a myth. I think it's completely wrong. It's something that we've sort of filtrated out to women. If you don't have children, you'll have more risk of ovarian cancer and endometrial cancer. I think that's wrong to put that into women's head, because there's no medical evidence for that. It was just a way of ploy of saying that your role as a woman is to have children. And that is part of why I started off this conversation saying medicine is misogynistic. And unfortunately, we've gaslit women far too long. But there's no evidence for that.
So there you go, you've been very patient.
Okay. I read Alison McGregor's book Sex Matters, which is really refreshing in how it approaches stuff, and it manages to merge cis women and trans women healthcare quite well, because it talks about hormones as kind of quite a normal thing for quite a lot of people to take, and kind of being part of the trans community, and also knowing about men going through prostate cancer and then having hot flushes and quite a lot of menopause symptoms. Do you see the conversations about menopause being beneficial to having, opening up a wider conversation about how the reality of people taking hormones across all ladies, and kind of normalising that and the effects of medication on that? Do you think conversations like this will help that much wider conversation?
It's a great question.
That's
really
such a good question, because it is a conversation that needs to be opened up more in regards to particularly testosterone as a hormone, because that's men and women. And we need to think about estrogen as something that men need. So COVID has really highlighted that men have become more severely affected by COVID. Why? Because men have a lack of estrogen. And there's studies that are ongoing. Professor Phil Spector is a really good person to follow. And obviously Dr. Louise Newson, who are doing trials and studies to look at this, because we've realised our immune system needs estrogen. The other conversation, which actually gets a lot of, it's slightly taboo, is the male menopause. I don't know if anybody's ever come across that term before, male menopause, but we realise that men also go through a lack of hormones, testosterone, particularly around midlife. But that is such something that actually I've actively had conversations with other doctors who refuse to believe it exists. But I think it does. It has to, because there is this transition in life that's happening, and it's because we're not designed to live past 40. Okay, as human beings, it's a machine. This machine is not designed to live past a certain age, but we are, because of modern medicine, and we've got great healthcare, and our bodies need to adapt, and so medicine needs to adapt with that.
Okay, we'll take 3 more questions, and then we're already at 6. I'm not quite sure when I'm sure Catherine will tell me when we're meant to be stopping. Are we still meant to stop? Okay. Can we take one more question? Okay, one more question. Okay. They don't seem to be banging on the back of the stage yet. Yeah.
I was just going to ask, do you not think as well that one of the things that goes hand in hand with vaginal atrophy is lichen sclerosis?
that incidence rises, exponentially at menopause, and so few people have even ever heard of it. I mean, I'm an electrologist predominantly, and so that's why the hormone thing is really, really interesting for me. And I'd say 9 out of 10 people, until they're actually diagnosed, or they say to me even, I've got this terrible itch, and I think it's thrush. Yeah, they go, have you had a look? Have you had a proper look at it? And because people don't look at themselves, they guess that. And by the time they've gone down and been told it's lichen sclerosis, they're again in a very difficult situation. I'm just wondering if that's something you find in practice.
So I've done a lot of stuff around lichen sclerosis on my social media. Lichen sclerosis is a fancy word for just saying eczema. It's a bit like an eczema. It's dry skin that occurs, and particularly around the vagina and vulva area, and it can happen at any age. So I can see some younger participants. Please get a mirror and start looking at your vulva, just like you examine your breasts. Yes. So you should be doing your breasts every month. You should be looking at your vulva every month as well with a mirror. And the reason I say that is because it will ever constantly change. Where you get lichen sclerosis, it's like this red soreness, and it causes this itch, and it burns if it gets into contact with wee. It gets missed because your own body will try and heal a little bit. It worsens because of estrogen not being there when you go through the change. And lots of doctors don't know about this condition. If it changes into these white little patches, it's called lichen planus. Lichen planus has a 5% chance of turning into vulval cancer. Vulval cancer is missed massively in the medical profession. In fact, lots of doctors don't even know that, or women don't even know that cancer can occur in that area. But I've picked up 3 women recently who've had vulval cancer because they didn't realise, and they were like, oh, but I was just told that this is maybe thrush, or it's just because, or they've been misdiagnosed as an STD. It's not. It's really important that we look at our vulvas and look at the skin changes, because they have serious consequences if we don't know what's normal for us. And as doctors, we don't know what's normal for you. So the only person that will know is you.
Wow, I think I've certainly learned a lot this afternoon, and I thought I knew quite a lot about menopause, so it's been completely fascinating. I'd like to thank my amazing panel. Sangeeta, thank you, and please go and listen to her amazing Masala podcast. Such interesting and important conversations. And Nagat, thank you for all the amazing, groundbreaking work you do. Just, it's fantastic that you're doing it, and thanks so much for all your amazing
I'm so sorry,
information.
it's really medical heavy. There's a lot of...
No, but there's such a massive information vacuum out there that actually you talking about these things, we're all educated women who should know about this stuff. I didn't know about half the things you were talking about, and it's part of my job to know. So I think that it just shows the huge amounts of ignorance around, and all the things that we should know and that we don't, and that we know about other things about our bodies, and how important this conversation is. So thank you for letting us do it, and thanks all of you for coming, and thanks to my lovely panel.
Oh, if anyone's interested, there's loads of free evidence-based information that you can take to your NHS doctor. So my handle across all social media is at Dr Nighat Arif, so DrNighat Arif, and you can share that. It's free evidence-based information and stuff that you're allowed to get and entitled to on the NHS. So please don't be shy. Be strong, and change is happening, I promise.
Yeah, and just as a final plug, the platform which Nagat and I are both on is called Noon, www.noon.org.uk, which is all about these kind of conversations, and we'd love to see some of you there. Thank you.